Dr. David Hughes, who is a consultant oncologist at the Royal Children's Hospital Children's Cancer Centre. It is an honor and a privilege to welcome you to our very first Australian Sickle Cell Advocacy Conference, which is running today and tomorrow. It is an honor to have you and to hear you talk about bone marrow transplant and providing an Australian perspective on that. So without wasting too much time, I'll give you the floor. Thank you.
Thank you, Natalie, and congratulations to everybody at ASCA for putting on such a valuable and informative couple of days. It's very exciting to be part of it. As Natalie said, I'm a paediatric bone marrow transplant physician here in Royal Children's in Melbourne, and I was going to just spend a few minutes running through some of the principles of transplant and just giving you some of our experiences. To understand the rationale for a bone marrow transplant, we have to just go back to some of the biology and understand, or to remind people how we actually make our blood cells. So just in our bone marrow, which is distributed throughout our entire skeleton, we have bone marrow stem cells, or hemopoietic stem cells to give them the proper name. And these are the cells that will then differentiate or develop into red blood cells of the different types of white blood cells and platelets. So obviously, in people with sickle cell disease, the problem is that the red cell manufacture from the stem cells has become abnormal. So therefore, the principle of a bone marrow transplant is to replace the hemopoietic stem cells with healthy hemopoietic stem cells so that we can make healthy red blood cells. Unlike when you think about transplant, I think a lot of people will think about operations. So if you think of a lung transplant or a heart transplant, you think of a surgical procedure where you replace the organ that isn't working. Bone marrow transplantation is very different. It's a medical procedure, so it involves drugs instead of surgery. And what we do is we use chemotherapy drugs to replace the hemopoietic stem cell, the bone marrow stem cell, which is making the abnormal cells, with a healthy bone marrow stem cell from a donor. Now, the problem with this is that because we're replacing the stem cell, it replaces the red cell manufacture, the white blood cell manufacture, and the platelet manufacture. It's not specific for one particular blood cell. So even though it's a very effective treatment, it's a bit of it goes hard because it hits all the different types of blood cells, not just one, even though in sickle cell disease, it's only the red cells that are the problem. So it's a sort of a non-specific sort of treatment, which therefore has a whole range of side effects. It involves really strong, intensive chemotherapy and immunosuppressive therapy, and as such, there it has risks. We have to accept the fact that there's risks both in the short term and the long term with bone marrow transplantation. In sickle cell disease, it's kind of interesting how bone marrow transplantation came around. So the first bone marrow transplant for someone with sickle cell disease was performed in 1984. In actual fact, the transplant was performed because this patient had a very aggressive type of leukemia called acute myeloid leukemia, and the treatment for AML is transplant. So this patient had a transplant to treat their leukemia, but as it happened, their sickle cell disease was also treated, and they were cured of two diseases at the one time. And that got people thinking that maybe we can use bone marrow transplantation as a means of cure for sickle cell disease. So since then, there's been well over 1,000 transplants performed across the world for sickle cell disease. And if we look at the statistics, actually the outcomes are really good. So this graph at the bottom, this is a chart called a Kaplan-Meier graph, which we use a lot in bone marrow transplant. And it really gives us an idea of the percentage probability of someone's outcome over time from the time of the transplant, if that makes sense. So, you can see that after 4, 5, 6 years after a transplant, about 94% of people who have had a transplant for sickle cell disease will be alive. Now, unfortunately, about 10% of those people will have had a recurrence of their sickle cell disease, but for some reason the sickle cell disease the transplant hasn't completely done its job. It hasn't eradicated the sickle cell disease, and the sickle disease has come back. So while you have 94% of people alive, 84% of them, those are alive without sickle cell disease, if that makes sense. And I suppose it's important to realise that this is a bit of a historical sort of chart, so that, year on year, these outcomes are improving. as we get better and better at doing sickle cell transplants and managing all the complications that can come with it. To give you an idea of the Australian experience, well, if we're honest, there's not an awful lot of experience in Australia because the sickle cell population in Australia is obviously much smaller than it is in other parts of the world. So since 2011, there's been 7 transplants for sickle cell disease performed in Australia. Of those, 6 patients are alive and well. And it's important to just notice that those 6 who are alive and well were all children. They were all under the age of 17 at the time of the transplant being performed. And they were all transplanted from a sibling, so a healthy brother or sister who did not have sickle cell disease. So our numbers in Australia are actually quite small if you compare that to other parts of the world, but I suppose what we do is we collaborate very extensively with other centres across the world who do much more sickle cell transplants, and some of us have come from other parts of the world where there is a bigger sickle cell disease population. So I think we are gaining experience and knowledge year on year so that our outcomes can hopefully match that of the rest of the world. First thing to think about is who to offer a transplant to. And it's a bit difficult. I think there's a lot of debate and controversy over who we should offer bone marrow transplant to. We used to use charts like this, where we would have criteria where people who, for example, for children under the age of 16, we would use certain criteria to say that these people should be eligible for transplant. Similarly for adults, and we'd have criteria to say when you should start hydroxyurea. I suppose now as time is moving forward, we're thinking more and more that if we have the opportunity to give someone a curative treatment, then perhaps we shouldn't withhold that until people have severe disease. There's potentially benefit to offering people a cure before they end up having things like strokes or frequent vaso-occlusive crises or chest crises. So I think there's a lot of debate across the transplant world about when to intervene and when to offer transplant to children with sickle cell disease. And it's, I think, something that we debate a lot. That was something that we would advocate that families, patients and families would have these discussions quite early, just so that we can do the right thing for the particular family. I'm going to just run through very briefly, because I know a lot of people in the audience probably haven't really had much experience with a bone marrow transplant. So I'm going to just run through quickly what the rough timeline looks like, or what the journey kind of looks like when we have a bone marrow transplant. It's a long and complicated journey. There's no sort of denying that. And the first thing that we do, once we've identified that the patient is a good candidate for a transplant, is we start making a lot of preparations. So the first thing is to find a good donor, and we'll talk a bit more about that in a second. And then we do as much as we can to make sure the patient is as healthy as possible so that they don't have, or to reduce the chance of complications. So we make sure the sickle cell disease is as well controlled as possible. So we have them on maximal doses of hydroxyurea. We might have them on transfusions to try and suppress their bone marrow as much as possible. We do things like inserting a Hickman line, which is this thing over here. So that's means that we can give chemotherapy and take blood tests through a vein so that the patient doesn't have to have lots of needles. And there are some other really important things that we focus on in these 3 months, and that's one is just preparing the patient and their family psychologically for the fact they're having a really big medical procedure, which involves a lot of hospitalization and potentially can make them very sick. And we also focus very much on trying to preserve fertility. So we know that a lot of the chemotherapy that we use in transplant can render people subfertile later in life. So we work very hard to do what we can to preserve their fertility. And that's a really important thing that we focus on, especially in Melbourne here. We have a really well-established oncofertility service who support all our families through this decision-making. Once everything's prepared, we admit the patient to hospital, usually about 10 days before the transplant happens, and this is where we start the intensive chemotherapy and immunosuppression so that we can create physical space in the bone marrow for the new bone marrow stem cells to come in and grow. We suppress the immune system so that you can't reject the new stem cells, and we give you lots of medication to prevent you from having infections. And then it comes to the actual infusion day, which is generally a big anticlimax because it really just seems like a blood transfusion in many ways. This is a bag of stem cells which will infuse into your vein. It takes half an hour typically. Just looks like blood. The patient doesn't even notice anything, and it becomes, it's a big sort of, after talking about this day for such a long time, it ends up being a big anticlimax. And then we have the first sort of 100 days, which is probably the toughest time, the trickiest time of the whole process, because this is where people can be quite unwell. This is where they can need lots of blood transfusions until the new stem cells start working. They can have lots of infections and fevers. They need a lot of support with their nutrition because their digestive system takes a bit of a hit during transplant. They don't necessarily eat very well. So the first 100 days can be quite tricky, but towards the end of that 100 days, then usually people will be much better. They'll be out of hospital, even thinking about going back to school soon, hopefully. And then they stay with us. They stay under our service for a very long time. So for the next couple of years, we watch them very closely as their immune system gets stronger. We re-immunise them because we've lost all the immunisations that we gave that the children would have had before the transplant. All those immunisations are wiped out by the treatment that we've given them. And we watch for all these different complications that can happen over time. So it's a very long journey. We work very hard to try and improve or to make the outcomes of the transplant as good as possible, to try and make it as a successful a procedure as we possibly can. And there's a few things that we focus on. So there's things with the patient themselves, like making sure that sickle cell disease is really well controlled. One of the really interesting things is about the age of the patient at the time of transplant. And this is a little chart again on these Kaplan-Meier charts that we look at lots. And this shows you that children under the age of 5 at the time of transplant have a pretty much a 100% probability of being alive after 4 years. So they have really good outcomes. If you're over the age of 15 at the time of transplant, then it's not quite as good. So it's about an 88% chance of being alive after 4 years. And if you're between 5 and 15, then it's somewhere in the middle, it's about 95%. So one of the things that we look at is to try and catch people, do the transplant at the right time when they're the right age to get as good an outcome as possible. We look at other things. We look at the donor selection. So we need to choose the best possible donor for the transplant, and we can look at a number of things like blood group or age or sex of the donor. But by far and away, the most important thing is looking at the HLA matching, and I'll explain what that means in a second. But this is really to try and match the patient's immune system and the donor's immune system as closely as possible. And we can see quite clearly on this little graph that if you have a donor who's a perfect match, then your outcome is much, much better than if you have a donor who's not as good a match. There's other things that we look at, like the chemotherapy that we actually use. So we know that from having looked at this for many, many years, that there's certain combinations of drugs and chemotherapy which tend to have a better outcome than others. And this is something that's continuously being refined. So just to talk a little bit more about how we select a donor. There's a bit of a hierarchy, so we tend to choose a matched family donor, which is usually a brother or sister, as our first preference. If we don't have a matched family donor, then we can look at an unrelated donor that we find on various registries. And if we can't find an unrelated donor, then we can think about using family donors who are not a match, not a complete match anyway. And we talk about a whole host of different things when we're selecting a donor, but as I say, the HLA typing is by far and away the most important. This is a bit of a complicated process, but just to try and summarise it briefly, the HLA system is a series of chemicals or proteins on the surface of all our cells in our body, which gives each of us a sort of a unique immune signature, so that our immune system knows what belongs to us, or our body knows what belongs to us, so that if something else comes into our body, it will have a different immune signature, and our body can kick in and get rid of it, because it's typically something like an infection or something like cancer, something that shouldn't be there. And the problem is when we're doing a bone marrow transplant, we need to get cells from a donor which are close enough, have a similar enough immune signature that our immune system won't recognise them as being foreign. As I said, the easiest way to do this is to find a brother or sister who's a perfect match, because like most things in life, we inherit half of our immune signature, or our HLA type, from our mother, and we inherit half from our father. So there's a 1 in 4 chance, or a 25% chance, that a brother or sister will have inherited the same halves as we did. So there's a 1 in 4 chance that a sibling would be identical and therefore would be a good match for a transplant. Downside of that is there's a 75% chance that our brother or sister wouldn't be a match. But if we can find a sibling match, then that's our first choice, because that tends to have the best outcomes for transplant. If we don't find a sibling match, then we look to registries across the world to see if we can find someone in the world who isn't related to you, but just by chance happens to have the same sort of immune signature as you do. So there's about 40 million people who across the world who have, very generously, kindly signed up to be a bone marrow donor for a stranger. For each of those individuals, there's about a 1 in 500 chance that they'll actually be called upon to donate their bone marrow. And there's also another just over 800,000 new parents who very kindly and generously donated their umbilical cord blood after the birth of their baby to a cord blood bank, so that a stranger somewhere in the world could use that if they need a bone marrow transplant. Here in Australia, there's about 175,000 people signed up to be a bone marrow donor if necessary. That's less than 1% of the population. So we would encourage people to go out and persuade their family and friends to sign up to be a bone marrow donor if they are eligible to. In Australia, the eligibility to be a bone marrow donor is that you need to be an adult under the age of 35, you need to have a Medicare card, and you have to be free, or you cannot have a number of medical conditions. Sickle cell disease is one of those conditions. It makes you ineligible to be a bone marrow donor, because obviously you don't want to transplant your cells into someone else and then give them a different disease. Australia also has a very big cord blood bank facility. So we have about 37,000 umbilical cords stored in Australia. We're one of the world leaders in umbilical cord storage. And when we look, if we are doing a transplant and we look to see if there's unrelated donors, there's about a 90% chance that we'll find a match somewhere in the world. The chance of finding a match is very much dependent on your ethnicity. So our immune signature depends on whereabouts in the world we're from. So your ethnicity plays quite a big role in determining whether or not you'll find a match. And to give you an idea of where we find our unrelated donors, so last year in 2020, all the bone marrow transplants we performed, so these are obviously not for sickle cell disease, these are for just any disease. When we looked to try and find an unrelated donor, about a quarter of them we actually found in Australia. About half came from Europe, with a few from North America and a few from Asia. Now, I suppose when we think about it in the sickle cell context, we can see that we didn't find any matches from Africa, we didn't find any matches from the Middle East, and only a few from the Indian subcontinent. And I suppose those are the parts of the world that people with sickle cell disease tend to hail from. So that's why we often find it difficult to find unrelated donors for people with sickle cell disease. If we don't find an unrelated donor, then all is not lost. There's other options, and one of those is to think about a haploidentical transplant. And this is a sort of a relatively new concept. So this is where instead of having someone who is a full match, we use a donor who's half of a match. So this is typically a parent who's given us half of our immune signature, or a brother or sister who's got half of the same immune signature as we do. But obviously, if it's only half of a match, then there's much more risk of the immune systems sort of attacking each other. So we have to do other things to try and control that. So these transplants are a bit more tricky. We do a lot of haploidentical transplants in this hospital for lots of other diseases, but we haven't done any for sickle cell disease yet. We are sort of excited about the prospect of potentially doing that in the future. But we have to realise it's a more tricky transplant, and perhaps there's more risk of complications. And that's because we have to do extra things to the stem cells to make sure that they don't cause any problems with the patient, because they're only half of a match. So the first thing that we do most often is we give some additional chemotherapy after the transplant is completed to try and wipe out some of the immune system from the donor, so that it doesn't cause a thing called graft versus host disease, which is where the donor cells attack the patient. There's other things that we're looking at as well, where we can actually take out some of the immune system cells, the T cells and the B cells, in the laboratory before we actually give it to the patient. This is this idea of doing a haploidentical transplant for sickle cell disease. It's a relatively new thing, and there's not that many patients in the world who have had a haploidentical transplant for sickle cell disease yet. There are a number of clinical trials looking at it, but so far published, there's only about 15 patients who have a haploidentical transplant for sickle cell disease. But if you look at the survival rates on this graph, it's astonishing. So the 100% of them are alive after 3 years, and 93% of them are alive without sickle cell disease after 3 years. So the early sort of numbers are really very impressive. Only 2 of those patients had acute graft-versus-host disease. 1 had chronic graft-versus-host disease, but they were all managed to be treated. So it's certainly here in Melbourne, we're sort of looking at potentially opening up our haploidentical transplant program for sickle cell disease over the next few years. I'll probably sort of stop there just to remind people that really at the moment the only curative therapy that we have for sickle cell disease is transplant. The outcomes are excellent, but you can't ignore the risks, and the risks can be very significant risks. And we're talking, we know that a very small number of children unfortunately do die after having a transplant, so we need to really sort of weigh up the pros and cons very carefully when we're having these transplant discussions. It's really important that we spend time planning the transplant really carefully so we can have as good an outcome as possible. And then, as I said, the haploidentical transplant using a parent or a sibling who's half a match looks like a really viable and interesting option for these patients. And there's lots of trials underway, and we will hopefully participate in some of them very soon. I might hand back to Natalie.
Okay, thank you very much, Dr. David Hughes. That was an excellent presentation. The one thing that really excited me is the prospect of having a program developed here in Australia. I know Australia is really, has always been at the forefront in terms of medical research. So I'm definitely looking forward to seeing that happening because I know that it will definitely provide a lot of hope and, for parents who are, for families who are affected by sickle cell disease. So I definitely look forward to seeing that particular development happening. We have a couple of questions, which you have answered, but maybe there is one. Can one donor have 2 siblings? It has been asked.
Can one donor donate to 2 siblings?
Yeah.
Yes.
Can that be possible?
If they're a match, then yes. So we've certainly got families who one healthy sibling happens to be a perfect match to more than one brother or sister. So theoretically, yes, absolutely they can donate. There are a couple of things we think about though. We really have to also protect the donor because these are healthy. The donor or a bone marrow transplant is a healthy person who ultimately doesn't gain anything from donating their stem cells. This is something they do voluntarily. They personally don't. It doesn't make them any better because they're healthy as it is. So we just have to always be careful that we don't expose a donor to too many risks. So that's one thing that we would really think about. If we're going back to use the same donor multiple times, then you'd have to really just make sure that you're not exposing that person to too many risks.
Okay, thank you. And another question that I would hope that you can answer is, does BMT erase the sickle cell trait? Because there are always many great conversations. I mean, as you know, it is challenging to live with sickle cell disease, and if one can access a cure, they're basically thinking this is the end of it all, So what does that mean for screening and also for our future generations?
Yeah, so there's a few things to say about that. It would eradicate sickle cell trait from your red cells if the donor doesn't have sickle cell trait. It doesn't. I think it's important to remember when you do a transplant, you're not changing somebody's genes, you're not changing their DNA. All you're doing is changing how they make blood cells. So if you are genetically someone who has sickle cell trait, then you will continue to pass on, or that you still have the risk of passing on the HBS to your offspring. You're not changing your own genetics. This is just how you make red blood cells. I suppose that's a really important thing to remember. And I suppose given the risk of a transplant, I don't think anyone would advocate doing a transplant for someone with sickle cell trait, because I think the risk-benefit balance then shifts too much in favour of the risk rather than the benefit. Everything we do in transplant is weighing up the risk and benefits.
Okay. And our very last question, I don't know how long it might take, is could you share a bit more about the process for donors? You know, how invasive is the procedure and are there any risks to them as well?
That's a very nice question. So the donor, because typically the donor will be a child or a brother or sister in the family. And what we do is we allocate a pediatrician to the donor. So someone who doesn't look after the patient, who isn't part of the transplant service. So a completely separate pediatrician looks after the donor to make sure the donor is always, someone's always fighting their cause and protecting them, because I suppose sometimes we as the doctor looking after the patient get biased. So it's very important that there's someone there to look after the donor. So they will meet a pediatrician to make sure they're healthy and fit and safe to proceed, to make sure that they understand what they're doing and that they give consent, or assent as we call it, in children who are maybe not old enough to legally give consent. And then the actual process of donating typically involves an anaesthetic. So the children will be anaesthetised. We use little needles which we put into the back of the pelvis, and from that we can take out bone marrow. So normally you'll have a needle on both sides of your pelvis when you're sleeping. We suck out bone marrow. It takes about an hour and a half to do that, to get enough bone marrow. We take the needle out, we put on a bandage. The patient will usually stay in hospital or the donor, will stay in hospital for one night, just for some painkillers and just to be monitored, and then they go home the next day. Their bone marrow is healthy, so they will recover from that super fast. Sometimes we give them some iron or some folic acid just to help with that recovery. But most children will be back at school after 2 or 3 days. It sometimes can be a little bit uncomfortable, a little bit sore, but it doesn't, they heal from that very quickly, and they have no long-term consequences from that. And again, they see their own pediatrician after about a month just to make sure that they're healthy and good.
Okay. Dr. Hughes, thank you very much for this great presentation. Thank you for staying to answer the questions. I hope that you will also jump into the Woover app, where I'm sure there are plenty of questions waiting for you. So it has really been an honor and an absolute pleasure to have you.